Hello, everyone. My name is Tiara Brooks, and we welcome you and thank you for joining us here for our Learning Collab. This is our final module of a four-part learning collaborative. Presenters will share 3 programs that utilize evidence-based guidelines for preventing, screening, and managing diabetes risk factors in elementary age children that health centers can bring to local centers. So once again, we thank you so much for joining us. I will go over just a few housekeeping reminders. All attendees are in listen-only mode. However, we would love to hear your question. If you have a question at any point during the webinar, please enter it during the chat box. We will answer questions following the presentation. Also, this webinar is being recorded and it will be uploaded to our website along with the slides in 1 to 2 business days. You can reference the link that is provided on your screen. Also, there will be evaluation poll questions at the end of the presentation. Your feedback is very important to us. I will now turn it over to my colleague, Emily.
Thank you, Tiara, and welcome everyone. Welcome back to those of you who have joined us for our previous 3 modules, and welcome to those of you who are just joining this special session that we're hosting today. I am Emily Kane, and I've been, along with Andrea from the School-Based Health Alliance, leading this learning collaborative. I come from the National Nurse-Led Care Consortium, which is a membership organization. We support nurse-led care at the front lines of public health care. We provide expertise around policy, research and advocacy, technical assistance and support, and direct nurse-led healthcare services. And I'm thrilled to introduce or be joined by my partner, Andrea, at the School-Based Health Alliance.
Great, thanks, Emily. I'm just trying to advance the screen here. Welcome, everyone. As Emily said, we're very excited for today's session, our final culminating session. I just am going to share a little bit about, hold on, this is not quite advancing for me. Wait a second, little lag, there we go. So I'm Andrea Shore, I'm with the School-Based Health Alliance, and as Emily mentioned, we've been collaborating on this learning collaborative focused on diabetes, prevention of diabetes risk factors for school-age children. And the School-Based Health Alliance is the national voice for school-based healthcare. We help support school-based health centers through technical assistance and training. We advocate for school-based health centers on the federal, state, and local levels. And we demonstrate the value of school-based health centers with common standards, measures, data, and research. Sorry, there we go. So just to quickly let those of you know who have not participated in our earlier sessions, we've been convening a learning collaborative of health centers across the country who were interested in enhancing efforts to prevent, screen for, and manage pre-diabetic indicators among elementary school-age children through partnerships with schools and other community organizations. And we've brought experts on throughout this learning collaborative to help provide some deep dives into this process and provide some technical assistance along the way. This has occurred over 3 sessions to date. And let's see here. So the goals and objectives of this learning collaborative have been that each health center would select an elementary school locally and develop an action plan for addressing elementary age children's obesity and other pre-diabetic indicators. And so we are wrapping that up with today's session. And last session, a couple of weeks ago, we also got to hear from an expert in the field about her program for working with medical students and bringing a nutrition and physical activity program to public elementary schools in Washington, D.C. So today we'll have the pleasure of hearing from 3 more programs and the experts who are running those programs. Okay, and we have communicated with each other through peer learning, through these learning collaboratives, and providing technical assistance in between. Okay, So our first session was identifying target population, where we really helped participants hone in on local education and health data. And then we dove into mapping your medical neighborhood and who potential community partners could be, in addition to working with a school. And so then today we're getting into some of the evidence-based programs to share with you. If any of these previous sessions are of interest to you, they you hopefully saw the links to those PowerPoint presentations in our prior, from our prior sessions listed on our website, as well as on the National Nurse-Led Care Consortium's website. So those will all be archived together in one place for your access at any point in time, helping to lead up to today. Okay, so for today's learning objectives, and I'm going to pass it over to our first speaker. Today we'll be hearing about the state of effective screening methods for identifying children at risk for diabetes, promising practices and programs for preventing diabetes in elementary age children, and some screening tools and interventions that some of the experts are going to share with you today that are built into their programs. So with that, we're going to go ahead and, Tiara, if you want to go ahead and pass over, I'll advance the screen one slide to Jessica.
Hi guys, can you hear me?
Yes.
Oh,
yep, you're good.
Thank you. Okay, so my name is Jessica Wallace. I'm a family medicine physician assistant, and I've been working in community health centers for the last 12 years. And so today I'm going to be talking about one example of some evidence-based program to address diabetes risk factors in the FQHC by talking about the MEND program at Denver Health. And it doesn't look like I can advance, sorry. Oh, there we go. Bear with me, guys. Okay, so the MEND program stands for Mind, Exercise, Nutrition, Do It. And it was actually started in 2002 in the UK. And so it's meant to be for children who are age 7 to 13 and their families. We at Denver Health have kind of bumped up those age ranges a little bit, which we can talk about later. There is a formal training for leaders. You don't need to have a dietitian on staff, exercise physiologist, nothing crazy. Anyone can go through the training and learn how to facilitate, and it's meant to be very out of the box. So with these pictures, I think, give a great example of some of the items that you get in the toolkit that help you to implement the program and then reinforce what the families are learning. This is not Denver Health data. This is actually data that was in the 2010 Journal of Obesity, and this is a randomized controlled trial that was done on the MEND program. And what it showed was statistically significant changes in waist circumference, in BMI, in exercise recovery heart rate, which is shown to be a marker for physical fitness in kids, and improved self-esteem. Those findings were all statistically significant at 3 months and 6 months, and also sustained at 12 months. And so this kind of data was important for us at Denver Health. Number one, because of course, randomized controlled trials are kind of the gold standard in terms of evidence, and also because we really didn't want to reinvent the wheel if we didn't have to, and have to like create our own program and figure out all that stuff. So a little bit about Denver Health. We are a large integrated safety net healthcare organization in Denver, Colorado. We do have a level 1 trauma center. We're integrated with our public health department, a whole bunch of other stuff. But my world, and for the purposes of this talk, we're talking about the outpatient community setting. So we have 9 community federally qualified health centers, and we see 1 in 3 Denver kids. And we also have 17, soon to be 18 school-based health centers. It's a lovely thing. So we all know the guidelines. U.S. Preventative Services Task Force says that we should screen for obesity, and then we should offer or refer them to comprehensive, intensive behavioral interventions. Statistically, that line of what was an effective intervention was 26 or greater hours of contact. And so that's what they defined as intensive. And so, of course, the question becomes, how do we do that? We have a large demand, right? I'm sure all of you can relate. In our system, we have about 21,000 overweight and obese kids. It's about 36% of all kids. And of course, large numbers of Medicaid, uninsured, underinsured, minority, Latino, everybody less than 200% of that federal poverty level at most. And also some significant barriers. So even though kind of throughout the years, intermittently, there would pop up these really cool grant-funded weight management programs for families, very few of our patients were actually participating. And even those who did participate, we just had little info kind of back to close that feedback loop. And so the question really became, how can we best comply with those guidelines? Particularly when this seems to be more and more of our lives in the primary care setting. We don't want to do more clicks in our EMR. So what we did was we basically did some research on weight management programs, selected the MEND program, and then brought it in-house into our community health centers so that we could hopefully reduce the barriers by offering the program in a familiar setting in their medical home. And so we started taking referrals from PCPs, and this could be in neighboring community health centers, or also school-based health centers could refer into MEND. And then pretty quickly what we noticed is we had a lot of referrals and a lot of participants. And so I think some of that was the increased legitimacy of this as an important component of their health, right? It becomes part of the standard of the services that we offer. And so that was reinforcing to parents that it was important. And then some of it was logistical. Patients' phone numbers, for example, change every 30 seconds. And, because they were our patients, we had multiple ways of getting in contact with folks when the first number didn't work as compared to kind of just crossing them off the list. So very quickly, we were able to scale up. This is a quick slide that kind of shows how the MEND curriculum is structured. And so it is compliant with that USPSTF guideline for an intensive intervention. Families meet twice a week, usually on evenings and weekends for 2 hours each session over the course of 10 weeks. The first hour, the parents and kids are together in the group, and they're kind of, each week it has different education topics, behavioral change supports, very interactive. And then in the second hour, they would split up. So parents would stay and have an ongoing discussion, and kids would go and exercise. They'd had structured physical activity. When we were taking this intervention and bringing it into a clinic setting, we knew we'd have to modify it to some degree, right? It looks different in the community, the space is different, all of that kind of thing. And so in particular, we don't have any of these. So, an hour of every single MEND session is play-based games, and we don't have a gym. And so, we didn't know what the impact of that would be. The reality is as health centers, we innovate. And so this is a lovely little picture of our basement conference room in one of our clinics. And, we stacked up the chairs in the hallway, we collapsed the tables, we opened the sliding little divider, and you make it work. I think health centers have a lot of really great experience with figuring it out. And these are outcomes. So this is older data. This is actually participants from 2015 and 2016. So when we first started these programs, I think we ran 8 programs. And what you can see on the left are all of the different measurements that we took. So the ones in bold are more of like the objective findings. So statistically significant changes in BMI and in Z-score. There's also down here that recovery heart rate test. And so again, we didn't have a gym. We didn't know if that would negatively impact, what the program kids were able to do in the program. And thankfully, it looks like even if you have a less than ideal space, you can still have a very positive benefit in terms of the physical improvements that kids make. A lot of these other things are more subjective, behavioral health-related behaviors, nutrition, physical activity, all of the usual stuff. And, when you look at this list, of course, how many of these are diabetes risk factors, right? We've got weight on here, we've got physical activity level, we've got all the nutrition. This data has been updated. The CDC actually has come out and been helping us, and I think they're even going to publish on it and showing some really awesome results. So we're excited about that. The other thing that's not on here too is that we later did kind of a very small evaluation of the parents who were participating in the program, and they also made statistically significant changes in health behaviors and some trending weight loss. So we know the connections between child risk and parent behaviors and health as well. So I think there's some cool opportunities there. And so the next question we asked ourselves at Denver Health as we had started kind of the next layer of bringing MEND in-house was a little bit more of an understanding of who is participating in MEND. And so we actually just did a chart review to kind of go back and say, you know, what's the status of these kids in terms of their health? And so we started out by looking at all of the referrals that we had gotten in 2015 and 2016. First off, we looked at how many of them had received the recommended screening guidelines. In particular, in this case, I'm talking about A1C, 44% had been screened. So definitely there was an opportunity there to increase our rates of recommended screening. And then this was the scary thing, is that when you looked at the number abnormal, which I'm talking about here, A1C greater than equal to or greater than 5.7%, 50% were abnormal. And I think this caught all of us off guard. We didn't really know what we were dealing with. And it's not just A1C. We also found a lot of other weight-related comorbidities. And even though, you know, MEND was this really awesome curriculum and patients were getting a lot of benefit out of it, they clearly were a lot sicker than what we had thought. And so the question kind of became, how can we best take advantage of the fact they are such a captive audience, they're coming into the clinic regularly, and be a little bit more tailored in our approach given how sick they are. And so what we created was we added on another layer of service. And so you see ignore the blue circle in the middle, you've got the normal kind of MEND curriculum, and then we just added on one-on-one provider visits. And so for those of you out there listening who have had any experience with group visit models, particularly centering pregnancy, or the Centering Healthcare Institute, that's definitely the model that we used when we were building this. And our overall goal was really to improve our evaluation and management of individual issues. And so, for example, by adding on that layer of the one-on-one provider visits, we could increase our recommended screening guidelines, which, given how high the comorbidities were, we felt like that was going to be a high yield to help identify these kids and support them in their medical management. And same thing with the workup and follow-up. We were able to tailor so that we were adequately addressing those comorbidities when they were found. In addition, as we had been going through with the grants before we had these one-on-one provider visits, you know, our families, of course, have really chaotic lives, and it's amazing the amount of things that would come up that people would have to confront over the course of a 10-week program. And so, and these were things that weren't necessarily well addressed or completely addressed within a group setting. And so by adding on this layer of provider visits, we were able to better address behavioral health, social work issues that would come up, and also connect them into other resources that we had within the FQHC. After we did add on that layer, we started doing some focus groups with parents. You know, was this a distraction, right? Those of you who do centering pregnancy know that there's this group that's kind of happening, and then you pull out patients kind of one at a time for the medical visit. You know, was that distracting away from the real curriculum, the real value? And the overwhelming response was that, you know, families really felt that the medical visit was a value add in lots of senses of the word. So that was very reaffirming. And then you get to a little bit more of the cynical side of things, which says that if you add on another layer of provider visits, that then you potentially create a path to sustainability. You know, we had proven that during the grant time that it worked, we certainly didn't want it to disappear like we'd seen other programs before. And so when we created this additional level, you know, we did our homework and especially around similar programs, and use standard E&M coding. You only do what is medically necessary and appropriate, and you bill it accordingly. So we are not doing time-based billing. We're not billing on anything that's happening in the MEND program itself. We're not doing group visit coding. This is just based based on that one-on-one time with the provider, the patient, and the parent. And then you have the FQHC reimbursement. And from there, basically, we just put together a proposal to submit to Denver Health. And, it was a big spreadsheet that said, okay, here is the projected number of patients that we can see within the MEND program in the upcoming year. And then, a thorough accounting of all of the costs that it would take to run the program. And, hopefully those numbers are close enough. It might not necessarily be 100% depending on all of those factors that vary from clinic to clinic, but if you can at least show that it can help offset the cost, then the ask for the health centers becomes lessened because you can show that, hey, this is a patient satisfier, this has great health outcomes, and so it's kind of just an extra win and kind of push to help do the right thing. So that's the approach that we've taken at Denver Health, and I'm happy to talk more about that. And I think the reality is that, we need all of these kinds of programs integrated everywhere. And so I think we, definitely have our work cut out for us. And I'm really happy to be part of this collaborative and looking for as many creative ways as possible as we can to champion this issue. And I'll turn it over to my co-presenters.
Evelyn, this is Andrea. You might still be muted because we can't hear you if you've started talking.
Can you hear me now?
There you go. You're good.
Okay, super. We're excited to have the opportunity to present with you all. I'm not sure if you heard the piece, but I've been in school-based telehealth for almost 20 years, and it's really exciting to see how it's grown, and really on this side of what we're talking about today, really looking at some of the opportunities for prevention and opportunities to partner across systems with our school colleagues. We just wanted to start off with admiration and appreciation for our participating families and communities. I believe that our colleagues at Community Health Center of Southeast Kansas have been participating on some of the Learning Collaborative, and we're really grateful, especially with their school-based health centers, and for the opportunity to be working with them. Our objectives today, first off, I'm going to talk some about our broader Telehealth Rock Schools program. We're fortunate to have HRSA funding to extend telehealth across developmental and behavioral health assessment and intervention. And as a piece of that is Dr. Davis's health psychology work around pediatric obesity and diabetes prevention. So I'm going to give the broad overview about evidence-based telehealth and considerations on the technology side, and then Dr. Davis is going to share with us her team's exciting evidence-based work around pediatric obesity. It's an exciting time for telehealth. And especially in working with children and families, there's so many advantages where you can really catch kids and families where they're at. And kids and families accommodate often quickly to the technology systems. You know, they've Skyped with their grandparents, or, you know, they've used technology in other ways. So it's a natural extension to utilize the technology for the delivery of health services. Telehealth really has great opportunities to help us think about bridging the gap with social determinants of health. I think the ones that we often think about are helping with transportation, and being from Kansas, where it may be a 6-hour one-way drive between one of our sites and the med center, and it may even be coming from a different time zone and coming in, that often the transportation piece is really helpful. And then, of course, the provider availability. But I think when we look at social determinants related to telehealth, the real advantage is how it can cross systems of care. So, of course, we're talking quite a bit today about the education and school-based system and how that we can all collaborate across school, primary care, and specialty mental health. This happens to be showing our provider availability related to mental health and behavioral health, but I think some of the same gaps and shortages of providers, especially provider and interdisciplinary teams who have the expertise in pediatric obesity, that's been a real advantage of the telehealth to bridge some of that gap. I think what we've also seen is, we see there's gaps both in rural and urban areas. And what we've seen with our telehealth programming is it's really champion driven, where we have champions in the urban areas and we have champions in the rural areas, and they're often driven by the same needs to meet underserved needs and to use the telehealth to do that. Across the telehealth services through Telehealth Rocks, we're really looking for the sweet spot that's a balance between quality and access, and always keeping in mind the patient's safety. I think what we've seen is, of course, the technology is cheaper, faster, better, which is awesome. It's just then thinking through all the details of making sure we're able to translate our very best services to the telehealth system. It is a good time in telehealth where we have a growing evidence base that technology delivery can work as well as in-person care, really across both behavioral health and then chronic disease management. There's growing evidence that telehealth can be effective. I think with that, our pediatrics, we're still building some of that evidence base, but again, when translated using our very best, it can be an effective way to deliver service. On the same front, there's a lot of professional organizations that have recently developed guidelines about telehealth best practices, and that's really been a great help in helping build interest and encourage telehealth practice. I think what we've seen with our own program and what many programs report is that telehealth is most successful when it's matched with the community need, the need that Denver just articulated, where it's really building on what the community is saying is a priority. And in our own state, we often do get the feedback across communities that healthy lifestyle and diabetes prevention is a priority, and telehealth is a good piece of that puzzle to meet the need. With our Telehealth Rocks and Telehealth Rocks Schools approach, it's really trying to look at telehealth on the communication side, so really using the technologies for a range of purposes. Of course, our big foundation is engagement of community insight and family support, and then leveraging the technology for assessment and as well as treatments for child developmental and behavioral concerns, and then also using it for education and mentoring. So we were really trying to pair the two things together with offering the education that is a need, as well as the direct patient services. So with our school-based telemedicine, we really see that it's answering the call in a new way. Our school-based telemedicine program began in '98, and again, it's evolved over time, but the reason it's been able to stay in advance is because it's really focused on the relationship and the community need, and the technology to help meet that need. We really try to approximate all the same elements as face-to-face care, keeping in mind that child telebehavioral health decisions with considerations and developmental consideration, parent preference, resources at the patient site, and the provider's comfort. This is just a range of the services that we offer. I think today, of course, we're focused on some of the feeding and weight issues with pediatric obesity and diabetes prevention. But one nice thing is across our behavioral services, we're able to then have that opportunity to refer patients to our Healthy Hawks clinic, where, for example, someone's gaining weight on a psychotropic, then they also have that ability to receive supports through the Pediatric Obesity Clinic. We also just wanted to give a shout out. We really try to include our trainees across telehealth services because we want to get them excited about the idea of using technology and also having the opportunity to do outreach and work with our communities across rural Kansas. Like I said, we have tried to pair all our clinical services with telemedicine opportunities and really get the biggest bang for the buck with the technology. Many of you have likely encountered Project Echo. That's our education approach that we're utilizing. And as you all may know, it's really similar to our learning collaborative idea that you all are participating. The idea is really to develop a community of learning, and through case-based interactions, really the idea that all teach and all learn, where our sites are able to bring their cases and interact together, as well as with the telementoring panel. We were fortunate Dr. Davis and her team did complete a pediatric obesity echo that was really well received. I think it was a neat echo in that we had both primary care and school personnel, and folks were able to share lessons learned across those systems. If from school lunch and helping support ways to get the special school lunch for students to lessons from our primary care as well. I hope you'll think some about telehealth. If you are excited about some of the telehealth opportunities, our telehealth resource centers would love to talk with you and support thinking through all the crossing the T's with setting up telehealth programs, a lot of the making sure that the administrative part can help support the exciting services that we're talking about today. If you are interested in the telehealth Resource Center resources, I'd be glad to talk with you more. And this is just a reminder of our national reach with the federally funded telehealth resource centers and the opportunities that they provide for technical assistance. I think with that, I'll hand it over to Dr. Davis.
Great, thank you, Evelyn. I appreciate that. So I am going to move on talking about a specific project that we have here in the state of Kansas called the I Am Healthy project. It is based upon the USPSTF guidelines that you heard about earlier. And so it's very familiar to the MEND program. I'd like to begin by acknowledging the co-presenters here today and the entire I Am Healthy team, including Dr. Evelyn Nelson, who's on this call, some graduate students, and then our project is totally funded by the National Institutes of Health, so we don't do any billing for this service. So that's not something I'll be discussing much today, the billing aspect of things. We've already heard a great deal about pediatric obesity. This is one of those great maps. So depending upon where you're listening from, you can look to see what the percentage of high school youth obesity rate is in your state. And there are lots of great maps that show these prevalence rates for all different ages. But either way, we all know that pediatric obesity is a health problem that it's important for us to address. And there's a lot of different types of research out there to show that individuals from rural areas have higher rates of pediatric obesity than individuals from urban areas. And that's true no matter the type of rural that you're talking about. So I just put this slide here to remind me that, you know, rural in North Carolina has just as much trouble as rural in South Texas, even though there are a lot of differences between working with those different populations. I'm in the state of Kansas, which is what you see on the screen here, and I work at the University of Kansas Medical Center, which is in the upper right-hand corner. We have a campus in Wichita of our medical school, which is the star more in the middle of the state. And so my challenge when I started at KU Med about 20 years ago was, how am I going to get 26 contact hours, which is what's recommended by the USPSTF, out to all these kids all over our state? So I wanted to challenge you all and ask you to do a quick interactive poll here. If you were me back in 2001, how would you deliver the rural family-based empirically supported pediatric obesity program to all these children and families in your state? So I can't vote, but I encourage you all to vote here, and we'll see what you guys would have done. Maybe 10 more seconds. All right, let's see here. Okay, so we have a lot of different responses, which always makes things fun. So 44% of you said during school hours as part of curriculum. There are actually existing pediatric obesity interventions that do that. The one that I'm the most familiar with is called PAC, Physical Activity Across the Curriculum. And it focuses on how to deliver physical activity as part of math and English. And so there are a number of programs like that. That's not what we're going to talk about today. There are other pediatric obesity programs that focus on after school, which was another response. And then there are physical or pediatric obesity treatment programs that focus on environmental changes, such as walking school bus and changing school lunches, which some of you mentioned. The option that we're going to talk about today is family-based behavioral groups via telemedicine. So some of you selected that option. So let's see here. So what I've done for the past almost 20 years now is do a series of studies to figure out how to deliver these types of family-based behavioral groups to rural Kansas. So we have done qualitative studies with individuals throughout our state. We have tailored treatment manuals. There are manuals for programs like MEND that exist, and so we tailored them for rural individuals in our state. And then we've done a series of randomized controlled trials. So the most recent one there in orange we're in the middle of it, but I'm going to tell you a little bit about it today. All of our interventions, just like the MEND program, have a nutrition component, a physical activity component, and a parent behavioral training component. We always include the parent and the child. And we also encourage other family members to come. So grandma, grandpa, aunt, uncle, siblings, everyone's welcome. And we focus on rural children and families. Like many programs, we use the stoplight diet, which has been around for decades. And there's lots of information about it out there on the internet. So in previous iterations of our program, you can see in this picture that that's me on the television. And these are a bunch of rural children and families gathered out at one of our sites in rural Kansas. But we have changed how we do things for our most recent grant. The first thing we've done is to increase our contact hours up to the 26 that you've learned about from the previous speaker. So we need to deliver 26 contact hours over 6 months in order to meet those guidelines. So for our current program, we're doing our groups, our family-based behavioral groups. We have 8 weekly sessions followed by 6 monthly sessions. And then we're adding on top of that 11 hours of health coaching. All of this is delivered to the home on iPads. So the kids all get tablets with a data connection, and then they and their families participate in the groups that way. Because it's a randomized controlled trial, kids and their families are randomized to the iPad or to the newsletter intervention, which you can see in the middle of the screen there. And they're randomized at the school level. So I have a picture of a local elementary school here to remind me to tell you that all the kids from each school are randomized to either one intervention or to another. So they know all the people who were on the iPad with them, and all the parents usually know each other too. These are 2nd through 4th grade children, so we're doing elementary kids. Our reviewers at the NIH always want us to exclude children over the 99th, so we only exclude them from our analyses. They are participating in the intervention, but we do a separate analysis with them included. I already mentioned our control group. We're adding some other measures to look at how group interactions change when we move from the first picture that I showed you where they're all in the same room to the second picture that I showed you where they're all on the iPad. And we've done some other operational changes, but I don't think those are very relevant here today. So in terms of partnering with schools, so as I said, we've done a series of studies, and what I've learned and what our team tries to focus on in order to partner with schools is how can we help them? What are their goals that they're working on that our project might be able to check off or take care of? So we help them with their wellness committees or with their school wellness plans, which they're all required to have. Some of them are interested in doing school-wide BMI screenings, just like they do scoliosis screenings or vaccination screenings or whatever. So we help them to develop a protocol for doing school-wide BMI screenings and how to give that feedback to families. And then sometimes there are other wellness initiatives that they might have going on that we can help with. In terms of how we recruited the schools for the current project, there's a list that you can get on the internet of all the elementary schools in your state. And so we got a list of all the elementary schools in the state of Kansas, and we send flyers to the principal, the gym teacher, and the school nurse giving them information about the project. Most of the time, it's the nurse who responds, but sometimes it's the principal or the gym teacher. We direct them to the website, which has a lot of information and is able to answer some of their questions. We've also made contact with schools over local listservs, and we try to really minimize the red tape that schools need to do in order to participate in research projects. So sometimes there's a lot of training that's required, but our institution has been great about helping us to individualize that training for this project and decrease it. So it makes the project more approachable for the schools, given everything else that they're focused on. We also try to make it as convenient as we can for the school personnel. So all the training is remote. We move at their own pace. You know, some of these school nurses have 2, 3, 4 schools that they're covering. So we really need to work around their schedules. And then at the end of all of our projects, we always do a report out where we tell them about the results of the project. And then we always leave them with the intervention materials, and they have been trained in leading the intervention. So the idea is that they can continue to offer these services in their own community. So that's all from me, and I'll turn it over to the next presenter.
Great. Hello, everybody. My name is James Huang. I'm a family medicine physician here in Washington, D.C., and I work at Unity Healthcare, as well as I'm a faculty member of a teaching health center here called the National Family Medicine Residency. And so I just wanted to give a little overview about our health center here. So here's a picture of our clinic with a colorful mural that was just completed last year. It's located in a bustling inner city neighborhood with a growing immigrant population. Our clinic cares for nearly 26,000 patients. About half are Spanish speaking, and about 70% are under the federal poverty line, and the majority are on public health insurance or uninsured. And as common in other parts of the U.S., in D.C., nearly one out of 3 children is overweight or obese, and many low-income families face barriers to accessing healthy foods. Oops, there we go. And so one way that we've just tried to address many of the barriers that our families face and move towards an equitable food system, we focused on group wellness visits, otherwise known as shared medical appointments, as a way to address chronic illness or prevent chronic illness and improve health outcomes. And so I was just wondering, for the folks that are listening, what group visits does your health center have? Or if you don't have group visits, what kind of group visits would you like to start?
Please go ahead and enter some thoughts to Dr. Wang's question in the chat box.
So someone said diabetic group visits. Some other group visits that we have at Unity are chronic pain group visits. We also, for a while, have had bereavement or grief groups. Any other folks, what kind of group visits do you have, or would you like to start? You can enter in the chat box. Great. They have we have mental health visits. They currently don't have a health coach or nutrition, but would benefit from a health coach. Great. So I think, as Jessica mentioned earlier, group visits are a great way to tackle or address a problem, whether it's centering pregnancy, which have shown outcomes by reducing the risk of premature birth, but also group visits are not unique to the medical field. Group visits are based also at Alcoholics Anonymous and Weight Watchers, which allow people to acknowledge that they have a problem and start working towards a solution in a supportive setting. Great. And then, so I just wanted to share some data from a recent study that was published by a group out near Boston. This is a wellness group that was led by a family medicine physician and a dietitian, and they looked at data from 2009 to 2014. They had about over 20 weeks of classes that focused on general wellness and sustained weight loss. Each group had about 6 to 15 patients, and they looked at five different educational domains, which included food quality, food quantity, exercise, activity, and sleep. And they found that the behaviors changed for their adults significantly, as well as sustained weight loss. The group lost on average 16.6 pounds, and 61% of patients lost at least 5% of their initial body weight. So giving more evidence that group wellness visits can be a great intervention. And so at Unity, while we were looking at programs, we adopted the National Health, Lung, Blood, and Institute We Can curriculum, which is a national movement that was designed to give parents, caregivers, and communities a way to help children 8 to 13 to stay healthy at a healthy weight. And so basically the focus is on improving nutritional choices, increasing physical activity, and reducing screen time. And so they looked at the outcomes for adults and children at 14 different sites across the US that ran the program in 2005. And the sites ran the program for 14 months. And in terms for the adults, they were found that out of 15 domains, there were statistically significant changes within the domains of energy balance, portion size, healthy eating, physical activity, and screen time for the adults. And then for the children, they also found statistically significant changes in 8 of the 14 domains listed here, ranging from food knowledge to physical activity and screen time behavior changes. So initially at Unity, we adapted the We Can curriculum, but over the past several years, we've adapted some of the elements of the We Can curriculum, but we've also grown our program through partnerships with community organizations and expanding through a program called the Fruits and Vegetables Prescription Program, now known as Produce RX. So now we've kind of broadened our scope and we call it Wellness Group Visits at Unity. It's a collaborative effort that focuses on engaging families, healthy eating on a budget, promoting physical activity, and connecting families to community resources. So basically how our program is structured is children are usually referred by their primary care provider if there's a concern about weight issues or families wanting to learn more about healthy eating. It's a weekly drop-in class that is offered all year round, and all of our talks and handouts are provided in English and Spanish. The team is made up of a registration clerk, 3 medical assistants, and 3 clinicians. We also have medical students and family medicine residents that participate in the class. So typically the families arrive between 5 and 6, they register, they have their weight, height, and blood pressure checked, and then engage in unstructured play, which usually involves jump roping, tag, and other physical activities. We also provide an assortment of fruits and vegetables to snack on. So we also built for the visit, as Jessica mentioned earlier, to make it sustainable. So there's a brief one-on-one with the clinician, which is documented in the electronic medical record, where we review health behaviors and knowledge. And then because we are billing for this clinic session, it counts as a 0.1 for the clinicians. And the class is usually about an hour and a half, where the first half is focused on a nutrition topic, and the second half usually involves some sort of physical activity. And we typically have anywhere from 5 to 15 families per class. And this is just some pictures of our EMR, which is eClinicalWorks. because in terms of, you can imagine, if we have 5 to 15 families, documentation can become overwhelming. So we've implemented a group visit template to assist with documenting, so we can see questions about their dietary consumption, exercise, and screen time from the day prior, as well as ask about nutrition knowledge, such as how many teaspoons of sugar are in a 20-ounce bottle of soda. And then we also do some goal setting with them. And then, so a unique part of our program is our unique community partnerships, which really enhances our programming. And we utilize the expertise of these community organizations, and have expertise in nutrition education. So the clinicians aren't planning each session. And then we'd also like to highlight some of our partnerships. And then through these partnerships, we've noted that families have a richer experience, and families tend to keep coming back. And so I guess for the next question, what are some challenges or barriers for you folks in creating partnerships with community-based organizations that could help support this kind of work? And then you can enter it in the chat box here. So, I mean, potentially, I think having the time, right, to meet with some of the contacts at these community-based organizations, or I know in the past we've had some issues with making sure that we had MOUs or memorandums of understanding. So I don't know if any folks have other thoughts about when thinking about creating a partnership with a community-based organization like a nutrition education group, or what challenges people have come across. Yep. So yeah, someone says time constraints, everyone is overscheduled. Yes, agreed. Great. So I'm just going to highlight some of our community partnerships that have helped support our program. So we have partnered with an organization here in DC called DC Central Kitchen, which focuses on culinary job training, healthy food access. They have a Healthy Corners program here in DC, where they stock corner stores with fruits and vegetables at lower cost for residents. And then they also help with nutrition education, and some of the pictures here from their classes with us. Next, we have DC SNAP Ed. Their programming focuses on eating on a healthy budget, and the team engages families. So usually we have adults in one class setting, and then the kids in with a different teacher, allowing for age-appropriate learning around a certain nutrition topic. We also partner with Common Threads. We're very fortunate to have a demonstration kitchen in our health center, where we can work with a chef who teaches our families on cooking and healthy eating, and they do a 6-week family cooking class. And so most of the meals are cheap and well balanced, and then they focus on whole grains and the My Plate method. And you can see here the kids getting excited about cooking and trying the foods together afterwards. We also utilize, I think I mentioned this in the first talk, the first session, but the Chop Chop. So we can often lead healthy cooking demonstrations using the recipes here, and Chop Chop is available to health centers for free. You can just go to the website and request copies to be sent to your health center. They're available in English and Spanish. Also, during the warmer months, we try to get out as much as possible. And one key partnership in supporting this is an organization called City Blossoms. And so we visit a community garden a few blocks from our health center every month and spend the evening harvesting, planting, watering, and then making a dish, usually from what we harvested from the garden. And then for the second half of class, we usually have some type of physical activity. We have a volunteer yoga instructor and Zumba instructor, so you can see that we were doing some yoga in the park adjacent to the garden one afternoon, and then we do Zumba in this as Jessica said, we make do with the space we have, and so we're doing it in the space outside the elevators on the 3rd floor of our health center. We also take families to the community pool, which is free to all DC residents from May until September. And then we also utilize our playgrounds and nearby parks for physical activity, which is the next slide. So we have a partnership with Rock Creek Conservancy, and they've led nature hikes and some forest bathing activities with our families. And as I mentioned earlier, a key part of our program is the produce prescription program. It's one of the unique aspects of our partnerships. And so this program is embedded in our wellness program. The produce prescription program starts in May when we recruit new families, coinciding with the beginning of the farmers market season. Produce prescription is a program funded in part Greens. They just programmed So brief overview is that 25 families are typically enrolled. And when those families come to the wellness group visit, we as doctors write literal prescriptions that families redeem for checks at farmers market. In prior years, the amount was based on family size. So a family of 4 would get $40 a week to spend at the market. Due to different funding issues, families currently now receive $20 a week, regardless of family size. But those checks are spent weekly on fresh fruits and vegetables. And so you can see the prescription here in the lower left-hand corner. And then each family is assigned a unique identifier. And then we're able to track the checks to make sure that they're being spent. And then there is a large farmers market 2 blocks from the health center, which we tour with families at the beginning of the season. And then because families have to come at least once a month to get their prescription, it's a great incentive for them to participate in the weekly class. We definitely see increased attendance during these months. And so not only is the program focused on fruit and vegetable access, but there's a strong educational component during the season where we teach families about the importance of eating seasonally, how to prepare and store produce, and overall address the access and knowledge barriers in our food ecosystem. And so this is some data from the 2017 season. And so as I mentioned, 25 families are enrolled. And so through tracking the prescription redemption, we know that the majority of families, 92%, completed the program, meaning that they attended 4 months or more of the group visits. And we're also able to track if checks are being used because it's a proxy for if they're eating fresh fruits and vegetables. And so we saw last year that 94% of the checks were redeemed by the end of the season. In terms of weight changes, we saw a 50% reduction in patient participants' BMI from the beginning of the program to the end. And even though it's like a small decrease, the focus of the program is fostering changes in health knowledge and behavior, which we capture from pre and post surveys. And so you can see here that 92% of families agreed, or parents agreed, that they were able to take better care of their health and learn new things about how to care for their health. 46% rated their children's health had improved. And then a third increased their knowledge about how to prepare fresh fruits and vegetables, as well as knowledge about where to buy locally grown produce. And so we have an abundance of success stories that are hard to measure or capture through surveys. And I just wanted to share a few of them. In terms of community building, a teenage participant invited the entire group to her quinceañera, or her 15th birthday party. There's a big community celebration, and you can see here, we actually gave out pedometers to all the kids. And so they were having dance competitions and dancing with the pedometers on at the quinceañera. In terms of connecting to local resources, every year that we go to the pool, we bump into families at the pool who learned about the pool from the prior years. So families continue to use community resources. In terms of changes in behavior, we often hear families say that they tried a recipe they made together at home and share pictures of the dishes, which are shown here. And in terms of knowledge and engagement, I wanted to share a story that highlights all 4 of these goals, including knowledge and engagement. And so a few years ago, a teenage participant wrote a testimonial about the impact of the produce prescription program. So the background is that every Saturday morning, he would go to the market to buy produce. And one of the farmers noticed how responsible he was and offered him a job. And this is what he wrote about the experience. He wrote, "It also changed my life because it made me less shy to talk to people, and I learned about new fruits and vegetables, and that makes me help the people who need the names of the vegetables. Also, I learned how to cook different plates with new vegetables and fruits. This new and sort of amazing way I got this job changed my social life and also my life with eating healthy and learning healthy foods." And so I just wanted to again highlight that this is a family wellness group model, highlights the value of strong community partnerships, which enhances retention and increases support for families toward achieving their healthy lifestyle goals. Again, we had weekly billable group visits, helping family engagement through community partnerships and collaborative efforts, as well as incentives through the fruit and vegetable prescription program. And I just want to thank our wellness team, the medical assistants, the patient registration clerk, and our other clinicians, as well as the support of the health center, Unity Healthcare, community partners, and our families. We have, these are not my kids, but another of the speakers' kids, and so I just want to open up for questions that you can put in the chat box.
Perfect. Thank you so much to all of our presenters. And this is a wonderful screen of one of our speakers' lovely children here. So we do want to open it up for everyone. If you have any questions, if you can please enter your questions into the chat box. And also just want to remind everyone that this webinar is being recorded, and the recording and the slides will be uploaded into our website. We will be sending a follow-up email to everyone, and will be available in 1 to 2 business days. And also for our attendees, you will receive a link to receive your CMEs for this presentation. So we do want to start off with a couple of questions. So for Anne, how do you get schools buy-in when you first want to launch the program with them?
That's a great question. I think as I mentioned in my talk, we send out the flyers. And so the initial step is theirs. They really contact us to express their interest. And beyond that, what we've really focused on is trying to figure out a way to deliver value to them while also decreasing some barriers. Usually they want to address pediatric obesity, so we're just trying to help them deliver a program that they feel good about without adding too much to their workload. The website has really helped because they have a professional looking bunch of information that they can share with their principals and other administrators to get buy-in at the building or the district level. So the website is something we've added for this particular study that seems to be helping a lot to get all those details out. I hope that's helpful.
Great, thank you so much. And for Jessica, about what % of your program do you fund through reimbursement?
Yeah, another great question. I would say, you know, when we did the proposal, we put it out that we were going to, our projections were going to cover 100% or as close to it as possible. And, you know, that was just making our case. You know, we didn't want to like shoot for something that we thought was totally unattainable, but we really did try to say how robust could we make this program and how many patients could we reach. Number one, because it feels good to reach more of that need, and also because that's the bottom line. You know, it's why I don't run large FQHCs and healthcare organizations, because I'd bankrupt the dang thing, but it really is about productivity. Productivity speaks. How many patients can you see? How many visits can you see? And when you look at 21,000 kids, you know, you do want to make some sort of a dent in terms of who gets the intensive program. So, you know, we are beholden to, you know, our leadership to make sure that we see good numbers of patients. And so we put that forward with our proposal saying we'd hit 100%. You know, I do not have people anymore breathing down my neck saying, what are you doing? What didn't you do? Counting pennies. But, you know, and so that's, I think, potentially something to consider. But I do think, you know, we really take seriously trying to make our reach as big as it possibly can because it helps patients and the organization.
Perfect. Thank you so much. And to James, could you envision a way to partner with schools with the way you implement We Can? If so, what would that be referrals to you, bringing elements to school setting?
Yeah, that's a great question. I think building off of what Jessica was saying, so unfortunately, our program is only open to the patients of the health center. So I think that would be the limiting factor in trying to think through like how would we recruit the whole school. But I think that's why some of the organizations that we partner with are established at local schools. Like City Blossoms has community gardens at different schools throughout the district. And then so I think maybe through that, like trying to strengthen the partnerships with those organizations and the elementary school. But I don't know if other people have other ideas.
This is Andrea, just adding into what James is saying. One of the, if some of you are considering trying to bring a program like his and collaborating with schools, but you don't have, we hear about this a lot where, yes, you're not serving all the students in the school. Sometimes sometimes depending on the data sharing agreements among your local Medicaid, your local or state Medicaid organizations and the school districts, sometimes they can share the data with you about which students in the school, or at least the school can know which students are a part of, assigned to your health center as a primary care provider. So there can be some collaboration that way, even if they can't necessarily share the data both ways with you. Sometimes they can know, and you could do some sorts of outreach or referrals that way through the data that the school is allowed to see.
I would also add that that's how, this is Anne, and in terms of the I Am Healthy program, that's how we wound up with the newsletter control group, is that the schools do want all the kids who are participating to receive an intervention. And I didn't have enough time to present much data today, and that's okay because we don't have a lot, but we have looked at the satisfaction data because we were wondering if the newsletter participants would feel like they were second-class citizens, so to speak. And they've actually loved it. So even something relatively easy to do, like a newsletter intervention, can be very well received by children and families.
Great, thank you. Would any of our presenters would like to add any additional information? Okay, we have another question. For Anne, what positive feedback have you heard from the schools? Are they noticing better attendance?
Ooh, attendance, that's an interesting one. I don't know that I could really answer that about attendance. The schools, the things that the schools have commented on are lots of them have reported that they don't want to screen BMIs because they don't have treatment programs that they can refer the kids to. So they really like having some options for the kids to participate in. They appreciate being trained in the family-based behavioral group program, and they appreciate having the newsletters. And so in our program, we're targeting 2nd through 4th graders, but many of our schools have said, hey, we want to do these newsletters building wide, or we want to use these newsletters in our middle school. And so they really appreciate having that resource that they can send home with the kids. I think those are the main types of feedback that we've received from the schools about the interventions, but I don't have anything specific about attendance.
Okay, perfect. Thank you so much. And this question is for Jessica. Looks very similar to James. Can you envision a way to partner with schools for men? Bringing those elements to the school setting?
Sure. I think, the advantage of We Can and Mend is that they don't have to be integrated into the health centers. So we brought them into the health centers and then modified them because that was what served our population best, but, you know, schools, if your population is the school, then I think the potential with those two interventions is they can be implemented in schools, right? And then you can tailor it based on how to best meet the needs of your kids and right. And so now the one thing is that we've looked at bringing in MEND into the school-based health centers is, you know, by default, these programs tend to be family interventions. And then all of a sudden you go into school, maybe the parents aren't necessarily there with them all day. And so does that become an after-school program, or can you think outside of the box? What does it look like if it's just the kids? How do you then communicate with the parents about the material afterwards? I think, you know, both of these programs have a lot of capability of modifying based on what your needs are.
This is Andrea and Jessica. Since you just started to say that, that was one of my questions, since I am able to chat outside of the chat box. So are both MEND, both MEND and We Can, even though I know they're evidence-based, so the founders allow for tailoring and utilizing that publicly, but it's flexible to use these in a variety of settings?
That is my impression. I think, you know, one thing we've experienced with MEND is that, you know, there is this sense of wanting to maintain fidelity to what works. And so again, the training is rigorous. There's a test, there's, you know, you use their materials. And so I think We Can is a little bit less strict about some of those things. But again, from my perspective, MEND does it because they want to make sure that if you're using that name, that you're not going to dilute too much the impact. But I think what individual organizations do from there is totally fair game.
Yeah, I agree. And I also just posted in the chat box the link to the resources. And it actually, I mean, We Can encourages non-clinicians to use the materials and integrate it into their setting.
Great, thank you.
We Can is probably a little bit easier to just go in and download the materials and kind of, you know, take it from there. MEND is a little bit more of like you establish a partnership and you sign up for the training and that kind of thing.
Great, thank you so much. Is there any other additional information that the presenters would like to add on also, or any resources that you want to provide for our participants? Okay, we thank you so much. We do have a few evaluation poll questions. If everyone can please just take the time to answer these poll questions. We will also be sending everyone the link to receive your CEs. So you can receive that now within the chat box, and you'll also receive a follow-up email that will include the link just in case you do not receive it within the chat box. So we just give everyone just a few moments if you can just answer the evaluation that's up on your screen currently. And while you're doing so, we would definitely, again, like to thank all of our presenters. And we truly appreciate you for taking the time out for this webinar today and open up this learning collab for everyone to participate. And again, this webinar and the slides will be on our website in 1 to 2 business days. You will receive a direct link via email to where you can locate this information. And once we conclude this webinar, you will receive the link also to receive your CE. Again, thank you to our presenters and our participants, and you all have a wonderful day.